This session is entitled Moving Fluidly Across the Translational Spectrum, and it's going to focus on the current opioid crisis. So I'm Catherine Chen. I'm from UCSF. I'm an assistant professor. My co-moderator is Mike Mathis from University of Michigan, and actually our entire panel is also from University of Michigan, so I feel a little outnumbered this morning.
Go blue.
So what we're going to do is we're going to introduce the speakers right before they give their talks, and we will save all the questions for the end. But I don't have to emphasize to this audience how important the opioid epidemic has been to the current public health situation, and we as anesthesiologists are perioperative consultants, so this is something that we obviously all care about. So our panelists have a very diverse background, and they are approaching the opioid crisis from different research perspectives. So we have the clinical, basic science, and behavioral health approaches to what we can do to improve the care of our patients. So Mike is going to introduce our first speaker.
Our first speaker, all of our speakers are from the University of Michigan, but the first speaker will be Dr. Jennifer Waljee. She's an associate professor for the section of plastic and reconstructive surgery at the University of Michigan. My experience working with her has really been as a resident in the ORs. I've been up on call with her. Maybe she may not remember this, but I've spent a couple late nights watching fingers being reattached, and not a very challenging anesthetic, but a very challenging surgery. So I'll definitely say that Dr. Waljee is a very talented surgeon, but her talents certainly extend beyond the OR. Her research examines variation in patient-reported outcomes across hospitals and surgeons, and she is focused on patient, surgeon, and hospital level factors that drive variation in care. And she does a lot of work with the opioid epidemic. Certainly, an engaged stakeholder in the opioid crisis is the surgery department. We're sending home patients with opioid prescriptions, and so she's been able to make a huge impact both through a program called M-Open, which is the Michigan Opioid Prescriber Engagement Network, but she's made a big impact locally, statewide, and nationally in her research studying how surgeons can impact the opioid epidemic. So with that, I'll give the floor over to Dr. Waljee.
Thank you. Thank you so much for the invitation to be here today. It's always great to hang out with you guys, not at 2 o'clock in the morning in the OR. So very glad to be here. I'm going to share a little bit today about Michigan Open. So this is a program that we developed about 2 to 3 years ago when we were trying to come around this concept of what is the role of the surgeon and the anesthesiologist in the opioid epidemic. So here are two of my colleagues, Mike Englesby and Chad Brummett. And so about 2 or 3 years ago, we started exploring this issue. My beginning interest when I first started on faculty was how can patient-reported outcomes be used to leverage surgical quality, and how do we use those metrics to define whether or not we're doing effective surgery or non-effective surgery. Around that time, we started coming around this concept of pain, and can that be measured, and then can that be captured? And from there, we started thinking about questions around opioid management. Several of my colleagues in surgery thought, well, I'm not really sure that surgeons play a role in that. But I think I'll show you some data in a few slides that we prescribe a lot of opioids in this country, and I think together we have an opportunity to really make a difference. So my funding and disclosures are largely related to the generous support from the Michigan Department of Health and Human Services. We're funded as a Medicaid match program, and in addition to the traditional sources of funding, I would really encourage you all to reach out to your state legislators and the Departments of Health and Human Services in each of your states. They've been very responsive to us and have been amazing partners. In addition to Blue Cross Blue Shield, that's the largest payer in our state, and I will allude to their partnership in a few more slides, but I've been blown away by their generosity and their support. Okay, so these slides will look familiar to you, that opioid overdose rates are increasing in our country, and that's certainly no secret, but I will also call your attention to the yellow line there. That's the Midwest sector of the United States where we live, and in the latter quarter of 2017, this rate of opioid overdoses has sharply escalated by about 70%. And statistics released by the CDC in 2017 suggest that we're now up to 174 deaths per day. And when we started looking at this issue, it was around 73 deaths per day. So I think we can all agree that this epidemic doesn't show any signs of slowing down anytime soon. I live in Michigan, which is a bright red state here on this map. We've actually gone in the last year or two from being number 18 in opioid-related overdose deaths now up to number 15. We write for 11 million prescriptions in our state. That exceeds the number of individuals that live in our state. And right now, there's estimates that deaths related to prescription opioids are about twofold higher than deaths related to heroin. The reasons for this are kind of unclear, but probably relate to the prevalence of those substances in our communities. So this next slide is data that was analyzed by Dan Larrick, who's one of our anesthesiology residents at the University of Michigan. And I think it's really telling because it shows from 2010 to 2016 the proportions of prescriptions that were provided by different avenues of care in our country. And you can really see where prescribing guidelines have kind of been targeted. So in dark blue, that's primary care and pain physician and pain medicine. The prescriptions have actually dropped from about 66% to 61%, small but significant decreases. In contrast, prescriptions related to surgical care have increased from 19% to 22% between 2010 and 2016. What's also important is that our prescribing for each individual prescription has also gone up, both in the total OMEs that we prescribe as well as the oral morphine equivalents per day provided in an initial prescription after surgery. This is in contrast to other new prescriptions provided by different subspecialties such as dentistry, emergency medicine, and primary care. So I think if we're going to figure out how to be effective stewards of opioids and how to be part of the solution, particularly as surgeons, it's important for us to reflect back on how we got here. So I'll go through a little bit of what I think the influences of that have been. So you all have probably all seen this paragraph. This is the Porter and Jick paragraph that was published in the New England Journal of Medicine. I started my internship in 2002, and at that time when we would prescribe opioids for people after surgery, we were consistently taught, largely by our chief residents, that it was okay to prescribe whatever because opioids if prescribed for acute pain are not necessarily addictive, and that was true for both oxycodone and OxyContin, so we prescribed quite liberally. This was published by the New England Journal of Medicine last year that shows how often and how often this article was cited and how frequently it was often misrepresented. And these may look familiar to you. I remember seeing these when I was in residency that really highlighted, again, the aggressive marketing campaigns around oxycodone and OxyContin, again, with the thought that they wouldn't be addictive, particularly in the context of procedural care, which is important for this talk. Now, of course, we know differently, and this alludes to the settlement that came out in 2007 by Purdue Pharma. So I get this question all the time. Well, why do surgeons prescribe so much? Why do they consistently send their patients home with 80 pills after a carpal tunnel release? So I think the reasons for that are multifactorial, and we'll explore some of them here. So first and foremost, kind of going back to the slide I talked about before, pain management has not been uniformly taught in surgical residencies. We typically learned how to prescribe opioids after surgery from our chief resident or from the nurses in the call centers to encourage us to prescribe more. They weren't addictive, and if we didn't prescribe enough, it was probably just going to result in more refills. So that has certainly been part of the problem. To understand that, we went back and looked to see, well, how much does opioid prescribing vary across hospitals in Michigan? And I think this lack of education and the lack of prescribing guidelines that we've had has had a huge impact on how much we actually, on the variation that we see in prescribing after surgery. So in some hospitals, in full disclosure, the University of Michigan is way over there on the left. We prescribe on average about 100 tablets after inpatient surgical procedures, but other hospitals in Michigan only prescribe about 20. So this is drawn from insurance claims data, which is powerful in many ways to capture the fill patterns. It does not capture consumption, and it doesn't capture patients who got a prescription but never filled it, but it does provide some eye-opening statistics about the variability and how much people are discharged from the hospital with, particularly when it comes to opioids. Sometimes there are policies and they kind of fall apart due to unintended effects and unanticipated other factors. So for example, right here in 2014, the schedule of hydrocodone changed, meaning that it went from Schedule 3 to Schedule 2. So for us as surgeons, that meant we couldn't prescribe for more than 90 days. In general, surgeons don't tend to prescribe related to days. They tend to prescribe more related around the number of pills that you're going to provide somebody. But importantly, it meant that we couldn't call in prescriptions and we couldn't fax them in and we couldn't provide refills. So we went back and looked, well, what is the effect of this policy? Because all of us had gotten comments back from our clinics, please make sure you prescribe more because you're not going to be able to call it in anymore. We don't want our patients calling for refills. So this is what it looks like when you look back at Blue Cross Blue Shield data. Invariably, the majority of our postoperative prescriptions are hydrocodone. And then thinking back a little bit more in that time, E-Prescribing in 2014 was not widely used. Even today, it's only used in about 30% of practices across our state. So what effect did that have? Well, sure enough, when we go back and look at Michigan medicine data from in 2014, there was actually a downward slope in hydrocodone prescribing before that policy. But afterwards, you can start to see the trend go up a little bit. What happened across our state? Basically the same thing. We saw an increase, a sustained increase by about 35 oral morphine equivalents immediately following the policy change in 2014. Unlike other specialties, such as specifically primary care, where they actually saw a decrease in opioid prescribing after this policy, we saw the opposite. There really wasn't any change in the total amount of oral morphine equivalents that were filled after surgery, which equated in this particular cohort to about 43,000 extra pills. And where that had probably the biggest difference, interestingly and unfortunately, is in our opioid-naive patients. These patients tended to be overprescribed opioids more than intermittent users and chronic users, and these are the patients who are going to be more likely to have leftover pills. So I think this particular example highlights a place where if we don't couple policy together with education, specifically in the context of surgical care, this is one example of that, sometimes policy kind of falls short. Other examples of where different factors may influence surgeon prescribing is around patient satisfaction and patient experience. So CMS has a series of surveys called HCAP surveys, and patients complete these when they're discharged from the hospital. And one component of these surveys is around pain management. And so, in fact, a couple of years ago, CMS actually advised that we should use these measures with an abundance of caution because it may perversely incentivize opioid prescribing. One of our fellows went back and looked at that, though, and found that HCAP scores actually weren't associated at all with the amount of opioids someone was discharged with after surgery. And I think that this highlights important evidence that we can potentially drop our prescribing without necessarily at the expense of patient satisfaction or patient experience. And as we were kind of going through this foundational work, we were trying to get at the factors of how are we really going to convince surgeons that they need to prescribe less? Another example of this is refills. We get this all the time from our surgical colleagues. If I prescribe less, again, their patients are going to call for refills. So what does this look like? This is data drawn from insurance claims. This particular data set is Optum. This aggregates insurance claims from United Healthcare. It also provides de-identified provider characteristics and patient characteristics. So it's a single payer, but it's pretty robust because it captures data across all 50 states. So we looked at a cohort of about 26,000 patients who had undergone a combination of inpatient and outpatient surgical procedures. On the x-axis, you can see the number of hydrocodone pills that were provided in the initial prescription, and this was to opioid-naive patients, so we would expect that they probably wouldn't necessarily need to refill. And we asked, what was the probability of refill? I initially was expecting that we would find this beautiful ROC curve, and I would exactly be able to tell you that if you prescribed 14 pills, that someone wouldn't necessarily need to refill. But we didn't see that at all. Actually, what we saw was that it didn't really matter how many pills you sent somebody out with. The probability that they were going to refill was around 6%, which I think suggests that patient factors are probably more important than the amount of pills that we send somebody out with. And I think what it also highlights is, again, another opportunity where we can drop prescribing and not necessarily at the expense of other measures of healthcare utilization. Another reason that I think that surgeons tend to prescribe so much is because they're trying to prescribe for a really heterogeneous group of patients. There's opioid-naive patients, certainly about 40 to 50, sometimes even 60% of the patient population, depending on the condition. About 8 to 10% are chronic opioid users, and probably harder to detect are the intermittent opioid users, or people who sort of periodically fill prescriptions across the year. And surgeons may or may not be good at asking these questions prior to surgery, and sometimes it doesn't show up on the MAR when we're doing our preoperative H&Ps. This is data led by Paul Hilliard from the Michigan Genomics Initiative, and what it shows is that these preoperative opioid users have an independently higher risk. They tend to present to us at an increased risk for postoperative complications related to tobacco use, the concurrent use of alcohol, substance abuse, depression, anxiety, fibromyalgia, and ASA class. So in general, these patients are at higher risk when they hit the door. And this is work done by one of our medical students, Dave Crone, that shows that these preoperative users do have poor outcomes after surgery. They're more likely to have higher costs of their hospitalization. They tend to have an increased rate of complications, and they tend to be readmitted more frequently, and they tend not to be discharged home. When we think about the fact that there's somewhere between 5 and 10 million patients or individuals currently in our country on long-term opioid therapy, there's about 9 procedures. It's the average number of procedures over a lifetime. That's about 90 million opportunities for us to coordinate, more often uncoordinated care for these preoperative opioid users. And what we've seen, again, in data drawn from Optum, is that this is really common. So whether it's because surgeons just aren't good at screening for these high-risk patients prior to surgery, or that there's some other inherent risk around using opioids is a little bit unclear, but there's no doubt that patients who present to surgery currently using opioids are more likely to have high-risk prescribing, specifically overlapping prescriptions, the concomitant prescription with benzodiazepines, and getting prescriptions from multiple providers. And what this yields is greater readmission rates and complications related to pain and opioid adverse effects. And we've also seen that postoperative complications are higher amongst preoperative users. This is, again, work done by Dave Crone that shows that there's a difference between 6.3 to 8.3%. Small, but a very real difference for our patients who present to us on opioids prior to surgery. And also, interestingly, is that it doesn't necessarily matter how recent the patient has filled opioids. There's some independent effect there, regardless of timing. Also, it's important to consider the patients that go on to new persistent use. And these patients are really hard to identify preoperatively. They didn't fill opioid prescriptions in the year prior to surgery. And the patient risk factors that underscore these patients is really hard to detect. But what we've seen, this is work led by Chad Brummett, published last year, looking at major and minor surgical procedures. The rate is about 6%. Also from that group, the rate for knee and hip arthroplasty is around 8%. For hand surgery, it's around 13%. For patients undergoing spine surgery, it's 13%. For pediatric patients, it's 5%. For cancer patients, it's around 10%. And for some cohorts of breast cancer patients, it's actually up to 20%. Again, these are patients who didn't fill any opioids prior to surgery and then leave the episode of surgical care, continuing to fill prescriptions for months after their surgical care would otherwise be considered complete. Work by one of our research fellows has now recently shown that this is true after wisdom tooth extraction. And where I think that this is important is we have randomized controlled trial evidence that shows that opioids aren't necessarily any better at controlling post-procedural pain for patients who are undergoing wisdom tooth extraction, and about 80% of these patients filled a prescription for an opioid. The rate of new persistent use is about 2%. So I think particularly as a surgeon who tends to see patients for, on average, probably about 2 to 3 months after doing a surgical procedure. What happens then to these patients who suffer from new persistent use? This is another one of our research fellows, Jay Lee, who looked at their trajectory. And for patients who develop new persistent use after surgery, they go on to fill about 6 tablets of Norco per day, up to about 6 months after surgery, which, when we go back and look at our chronic users, that's about where they fall, kind of right in the middle. And more telling, who ends up prescribing for these patients? So invariably, this ends up falling back on our colleagues in primary care and medical subspecialties. And the cost of this is not insignificant. So for patients who develop new persistent opioid use after inpatient and outpatient surgery, that yields an excess cost of about $8,000 and $2,000 respectively. And it's compounded when patients develop surgical complications, so about a $20,000 or a $10,000 increase in expenditures, which, if you do some fast math in our state, in Michigan, that's about $466 million per year in extra expenditures just related to new persistent opioid use alone. So with this evidence that we developed, we wanted to ask, well, can we actually convince surgeons to improve their prescribing? Do we have an opportunity here to do that? And I think the answer is, of course, yes. And we've gotten to see pockets of a lot of this work in different places and different institutions. So I'll share with you one of the examples that we have from the University of Michigan. And why I think this is really important is because although we started with work around the chronic opioid user, invariably, probably the part where we contribute the most as surgeons is in our excess prescribing. And those pills end up flooding the communities and are clearly the gateway to later substance abuse. So we've really shifted towards a preventive model with respect to the opioid epidemic and thinking about this. And here's an example of how we can make a difference. So if you think about laparoscopic cholecystectomy, one of the most common procedures performed in the United States, one of our medical students went back and looked to see, well, on average, how many opioids were patients prescribed after this procedure? And it's interesting. Some people were only given around 8 to 10 pills. Some people were given 120 pills. And about 77% of prescriptions somewhere fell in around this kind of 50 pill range here. And then Ryan went back and called all of the patients to find out, well, how much did they actually take? And you can see the curve clearly shifts and is not in the range where we tended to prescribe at all. And on average, people took around 5 to 10 pills after this procedure. So Ryan came up with some really simple guidelines: 15 tablets of oxycodone, 15 tablets of Norco, and probably even more importantly, coupling it with Tylenol, Motrin, and patient education. And he delivered this as a single educational intervention in November of 2016. And here's what prescribing looked like before. It was widely variable, and it was, in general, in excess. And afterwards, it dropped. It narrowed, the variation narrowed substantially, and I think what's really important about this slide is that the drops was sustained even through August of 2017. And if you think about all of us that work in an academic institution, this reflects the number of prescribers that turn over on that service every single month. We didn't see a jump in that, and it reflects the change in the influx in a new group of interns and residents that came in July. It didn't jump up after that either, which I think highlights the important opportunity we have within the culture around us that we can inform each other's prescribing and have a sustained effect. So with this single intervention, this was a 370 patient cohort. If you think about the fact that we dropped our prescribing by about 30 pills per patient, that was about 13,000 pills that Ryan was able to keep out of our communities just from lap chole alone. And this aligns with other data. This was published by Hill in 2016 from Dartmouth, again showing that about 70% of the pills that we prescribe as surgeons go unused. If you think about just in Michigan that we prescribe maybe about 30 extra pills per prescription and we do somewhere around 1.9 million operations, that's about 62 million pills that go unused in our communities alone just from our excess surgical prescribing, again, because we haven't had guidelines and it's been widely variable. That would fill up all of our stadium and 2/3 of Yost Ice Arena. And so getting back to these factors, what motivates surgeons to prescribe and what is going to be the barriers and roadblocks for them to change their prescribing, we went back and asked what was the refill rates, what were patient-related pain scores, and we found, again, there's no change in the calls for refills. There weren't any changes in patient-reported pain scores after laparoscopic cholecystectomy. And interestingly, patients actually consumed fewer pills when we wrote smaller prescriptions. We see the flip side of this effect in fast food marketing in this particular example, but I think it highlights an opportunity for us to really change the way patients think about pain when they enter the preoperative period and change our culture about how to manage pain. Also, what's interesting to think about is the spillover effects just from this single educational intervention. This was all designed around laparoscopic cholecystectomy, but it clearly prompted prescribers, at least at our institution, to think critically about their prescribing for other conditions. So, for example, a sleeve gastrectomy, an appendectomy, an inguinal hernia repair, and a thyroidectomy. We saw drops in prescribing for each of these procedures as well. So, Mike, Chad, and I are obviously in an academic institution. We're in academic practice, and we all spend a lot of time doing research and thinking about data sets and thinking about manuscripts and grants and all that kind of stuff. But I think where this partnership has really changed my thinking about this is how we can make impact in our communities, and specifically how we can partner with other groups, because this problem, as you're going to hear from all the panel, is so complex. There's no way that an individual surgeon or an individual anesthesiologist or an individual epidemiologist is going to be able to fix this. So instead, how can we come together and make the broadest impact? So I'll highlight here the CQI programs in our state. So in Michigan, Blue Cross Blue Shield, again, as I alluded to, is our largest payer. And so what they've developed over the last 10 to 15 years is a network and partnership across hospitals to essentially pay for participation in hospitals' feedback outcomes, then come together in quarterly meetings and decide on the aspects of surgical quality that they want to target and improve. And what that gives us is a powerful framework that we can develop best practices around and then make statewide change. And why that's important, I think, is because I am a hand surgeon. And so if I go to talk to cardiac surgeons, they're not going to listen to me about prescribing recommendations. They want to hear it from their patient population and from people that are in their clinical space. Similarly for those of us in hand surgery, those of us in general surgery, et cetera, et cetera. So it's really important that we're able to engage all of these different prescriber and provider groups. And if you overlay all of the hospitals that participate in these networks, they overlay very nicely with the opioid mortality map that's in our state. Again, highlighting an opportunity where I think we can make a real difference in our communities. And these are our partners. So there's Chad in the blue shirt, Mike Englesby, who's a transplant surgeon at Michigan, next to me. Chris Priest is the former deputy director of the Michigan Medicaid program in the Department of Health and Human Services, who helps sponsor our program. We meet with these individuals regularly. We have calls every other week with them. They've been incredible partners. And then Tom Lydon from Blue Cross Blue Shield is on the far left. And this again highlights the programs that are in Michigan. Again, the importance of really being attuned to the clinical condition that we're trying to develop best practices around. We're housed here at IHPI. And I think, in addition to research and writing papers, one of the most important things we can do in our communities is figure out ways that we can create convenient ways for patients to dispose of their opioids after surgery. We've clearly demonstrated that we prescribe a lot. And I would say right now that patients' access to disposing opioids is largely limited to law enforcement agencies. And particularly for our patients who are struggling to drive after surgery, they're still in pain, they're dependent on their loved ones for care. This can be really challenging. Chad Brummett has spearheaded this entire effort. The first one was several years ago in Ann Arbor, and we had one back in September of 30th. We actually partnered with around 7 to 8 sites around our state. And these are the statistics. We had 766 people visit this event, just this single event. We took back 900 pills. 17,500 of those were opioid pills. The oldest opioid from all the events is from 1976, and the most common reason people bring back opioids is leftover pills from surgery. So again, Chad's developed a very powerful resource for us to be able to understand what are the effects of our overprescribing in our communities, as well as doing a tremendous community service. And in fact, right now, it may actually be wrapping up. We're having a take-back event back in Michigan now with 27 sites. Again, leveraging our structure across our CQI programs in our state to make a difference in all of our communities. These are a single event, though, throughout the year. We host them twice a year, but what do patients do kind of on a daily basis? So in our program, we've assembled a team of students. They essentially update a take-back map every single day because there's differences in each site with respect to whether they can take back liquids or patches or pills, and this allows us to give our patients real-time information at the time of discharge about where they can take their medications back. I also think a really important arm of our work is taking our data that we've gathered and this evidence and using it as an avenue for advocacy and to inform policy, because I think specifically the hydrocodone example illustrates a place where policy is largely designed to encompass all aspects of care, but it may not necessarily be attuned to the nuances of surgical and perioperative care. And without coupling it with appropriate patient and provider information, sometimes things can fall apart. I think that's a place where we can be really useful to go back to our legislators and our policymakers to try to help inform this. This is going to be critically important coming up because about 26 states already have instituted prescribing limits. Most of these are around 5 to 7 days. Some are as short as 3 to 4 days. In Michigan, specifically, this is going to be limiting prescribing of opioids for acute pain to about 7 days. But again, I think sometimes this policy may not necessarily be attuned to how we think about prescribing in the context of surgical care. Because if you think about the signature for this prescription, if I wrote for 1 to 2 pills every 4 to 6 hours as needed for pain for 7 days, I can still prescribe up to 84 pills. And you can see from the prior example that patients certainly take far less. Here's again highlighting this. There's a sustained increase in this in opioid prescribing when it's not coupled with education, yielding 43,000 extra pills. So where can we do things better? So here's an example from MSQC. So we actually went to the MSQC program. This targets general surgery and vascular surgery procedures, and they touch about 72 hospitals in our state. We collected data from patients to try to inform prescribing guidelines. We looked at consumption and we looked at prescribing. And again, you'll see similar gaps to what we saw for laparoscopic cholecystectomy. We prescribe far more than our patients consume. So we developed these guidelines. We've actually implemented them across the state. They went live in October of this year. And these are the revisions now because we have an opportunity to continually collect data from patients. We can actually push these prescribing recommendations lower by about 20 to 25% in the last iteration. We've been able to partner with Blue Cross Blue Shield to find ways to incentivize providers to have these important conversations around pain management and pain expectations. In July of 2018, this will actually be included as a modifier 22. That means is there will be enhanced fees by about 35% for patients who are able to undergo these surgical procedures with basically opioid-sparing postoperative prescribing. I think another important opportunity is the opportunity for shared decision making. So now in our state, we have the opportunity for partial fills. We've developed instruments that we can use at the bedside to counsel patients around prescribing, which also highlights policy that's been put in place around informed consent for the risks of prescribing an opioid, specifically the dangers of addiction, proper disposal, the delivery of a controlled substance is a felony if not under the constraints of prescribing, and for pregnant and female patients. And we have to be able to document this. So what have we been able to do around that? So we came together with individuals in our communications department and developed some patient materials that highlight this, that are all on our website. And health systems can now brand these for their own use. We make these all publicly available. We give them to our patients after surgery. And we've also got links back to our disposal resources. So I think all of this work highlights an opportunity where not just health services researchers, but when we collaborate with individuals from social work, primary care, education, public health, public policy, psychology, and statistics, we can come together and make a difference so that we don't just write another paper, but we do something that will really impact our patients daily. So this is our team, and I'm happy to answer any questions. Thank you.